right? Yeah, let's talk about DI. So they're missing ADH, right? So we talked about the points of being copious amounts of diet. That's always right there. Possible hypovolemia or severe dehydration. We're out of worry about that. And what causes it? It's a lack of what hormone? ADH, right? We have a lack of ADH, which will explain a couple things here. Yes, a lack of ADH. So if you have a lack of antidiuretic hormone, you're going to be feeling crazy. You're going to be feeling love. So in your serum for DI, is it osmolality going to be high or low? It's going to be high. So let's answer that. That's the thing. Why in DI is the osmolality high? There's two answers. Yes. Yes. Very good. That was very good. What she said. So what she said was the water is moving through the kidneys so quick that the kidneys cannot put out the salt, the solute, right? It doesn't have time to concentrate the urine. And what does it mean to concentrate the urine? Is to throw out the salt, dump the salt. That's called concentrating that urine with solute. And the water's flowing through so fast that it's like a filling station for solute that the kidneys can't say, okay, dump salt, dump salt. But where does it stay? In the blood, in the serum. So that's why you guys are going to have a high serum osmolality. Now the urine is quite the opposite, would you agree? So what's the urine going to look like? It's dilute like crazy. Does it look like water? Yeah, it does, for the same reason. So you have a low here because, again, for that reason, one of the reasons is too fast. Number two, I say too fast, moving through. And number two is a decreased ADH level, an adequate ADH. Now you have to think about what it's going to do. What does ADH tell the kidneys to do? Dump the solutes. It does. It really does. It'll say, hey, I'm ADH, but I'm telling you, kidneys, to dump and concentrate the urine. But without enough ADH, the kidneys are not being instructed to do that. See? So the lack of ADH will result in very little, very little solute. Because part of its job is to do what again?
Concentrate.
That's right, to concentrate the urine. But we have the lack of ADH, so you're not going to concentrate the urine. Could you feasibly, if you keep this so simple, can you just memorize what's high and what's low and get by? You know why I say that? Is because it's completely opposite with SIDH. So if you are still struggling with the concepts of how it works, you can just memorize this stuff. Literally. It's best if you know it to understand it. Because like a year from now, let's see, when you guys remember in August? December. You're 12/23, right? Yeah. So you can then in December still remember because you know it. You know why. You know all the why. That's the best way to learn. But just not be crazy. So like, yeah, test on Friday. Could you just memorize what's high and low and get by? You could. It's not ideal, but it can be done. Okay. So DI is high in the serum. DI is low in the urine. And then the correlating spec-graph, specific gravity, when you have a low osmolality, urine osmolality, your specific gravity is also going to go low. That's easy. Because what that measures is kind of a way of measuring the concentration of solute in the urine. As evident by, if you have, the more solute you have, you think you have more of a gravitational pull. Yeah, it has more gravity. It's easy though. Low your osmolality, you will also have low specific gravity, and that's what you guys are asking. So we've got, let's see, low urine osmolality and also low specific gravity. Spec gravity. Coming higher in a second. Yeah. Because remember specific gravity is all about concentration, right? Would you agree the more solute you have in your urine, the more gravitational pull? It's heavy. It's heavier. So you're going to see it opposite on this side. So let's do this side. So what is your serum osmolality on this side? Yes. What would that be? Because it's opposite. Did you say this is opposite of the other side?
Yeah, it has more ADH.
And what does ADH cause you to do? Retain
Water.
water. Or are you then diluting just pouring water into your vasculature? Fill it up. Fill it up with water. Is that diluting your sodium concentration? And we're dealing with sodium. Luckily, there's not more solutes that we're dealing with. So the primary solutes. So right here, we're going to have low osmo. And let's go down to the urine. High or increased. Right? Increased or high. Now why do you have increased osmo here and increased specific gravity? Think about that. Now they're oligomer, right? They're going to let out some of the urine. Not a lot, but they can keep some. Because what does ADH do? It gives it the time, right? So does the kidneys have time to say, salt, go out, to concentrate that urine, right? Is it opposite of DI? What's the other thing that ADH does? Tells the kidneys to concentrate the urine. Is that making sense? So that's why you're going to have increased osmolality here and increased specific gravity. Is it sort of it?
The only thing that kind of just threw me off was the high osmolality.
Because on the top of the SIVH, you say the serum is low for osmolality.
Yeah.
And the bottom one
Are
that
you saying that
you
it's
say
high
the
for
high
urine
osmolality?
Yeah. Because the urine is able to be concentrated.
Oh, on the superiorly on the gut.
Like,
Yeah.
So, no, what I was saying is that there's the osmolality for the serum and there's an osmolality for the
yeah.
urine. So that's why I was saying confused. I thought it was just
And those
general. But I
those
didn't
are-
realize it's low osmolality for the serum and the GI.
Osmolality just means concentration.
Yeah, that's right. That's exactly right. So when you're working in the hospital, this is how they diagnose it, right? This is one of the things that, so you're at the hospital and you have a patient who has either DI or SIDH. You look at your labs and you go, oh, I get it. So the serum looks either low or high, and the urine looks either low or high with osmolality. Yeah, they're actual measurements. Yeah. So they're good diagnostics, and they're good for us to know what is what. Oh, yes.
Let's explain what specific gravity is.
Concentration. Yeah.
So specific gravity also fits into
Yeah.
urine.
That's how you want to think of it.
Okay.
Yeah, you're welcome. So would you say the higher concentration, the higher the specific gravity?
Yes.
Yeah. That's a good way to sort of simplify it anyway. What I like about these correlate. Up, up, down, down. So that's a good way. So you don't have to think, oh my God, too many arrows. The only arrows that are opposite are really these two. These are going to be the same. Isn't that great? So you have them. So let's do it again. I'm going to quiz you guys. Should I erase it? Did you guys want to take why it's like it is. Because how do you understand why? Because you have to know what ADH does. ADH is more than just, compensatory, like holding up the urine when you don't have enough volume or holding on the water. So that's what it's designed to, compensatorily. But it does a lot more. Again, the other role that a lot of people don't think about is ADH has kidneys. You need to concentrate this urine in a normal way, right? But without ADH, it doesn't do that. So that's why nothing ends up in the urine. I mean, you look at it, it looks like water. All right, we'll go back to this. I'll leave this up, and then we're going to finish the exam review, and then we'll go back to the hardest part. But y'all can get this. We can easily get this right on your chest. Okay, so where are we? Oh. Let's go back here. Okay, excellent. Oh, let's do some thyroid. Yeah, you answered. Did you answer some DI stuff? You didn't. We just did it, so we'll go back. Thyroid. So you have some hyperthyroidism stuff going on. What are some of your findings? Can you yell?
Q4, nervous, irritable, increased appetite, weight loss, eating tolerance, exophthalmos,
Yes.
large thyroid,
Yes.
increased blood pressure.
Yeah, very good. I think I heard most of that. She said about 7 or 8 things. Did you say tachycardia?
She did.
Yeah.
Okay, did you say increased T3 and T4?
Yeah.
Yes. And what is your TSH level? Low. Good. Does everybody understand why the TSH is low? Because you have plenty. Thyroid stimulating hormone doesn't need to, it needs to back off, with the feedback loop, right? Because you have too much. Irritability. How about hypertension? She said that, right? Mm-hmm. TSH is low. Let's see, what are the other ones? How about insomnia? Mm-hmm. Yeah. The metabolism plays a big part or works alongside with sympathetic nervous system. Can you have chest pain? Yeah, so everything is up. Can you have diarrhea versus constipation? So what I'm trying to say here, is this like DI and SAADH, where you do a side-by-side comparative? That's how my test question is going to look. You see where I'm going? You're going to have some things that are going to be hypothyroidism, some are going to be hyper in the same question. Is it a select all that apply? Of course. So you have to know them, and you have to say true or false. Is this for hypo or is this for hyper? And choose those. Okay, very good. All right. Let's go to the front of the class. Where are we? And I think we're making pretty darn good time here. We have, I'm loving this, neurogenic shock. You have a patient you just received in the emergency department, and they're suspecting a spinal cord injury, which caused neurogenic shock. So what are your findings with this?
Bradycardia, hypotension.
That's pretty much all you need, isn't it? And I also need a descriptor of what happens pathophysiologically. You have a loss of sympathetic tone. That is so good. Really good. And that makes sense, doesn't it? That describes the bradycardia. That describes the hypotension. So when you say that you have a loss of sympathetic tone as a class, what does that mean? Do the catecholamines get all screwed up? Sympathetic. So what describes the hypotension? Vaso versus Because catecholamines, sympathetic nervous system is responsible for vasoconstriction, which I'll agree. And then, what about the braided, bless you, what about the braided cardia? What? What's going on? We have got a thing happening here. So why the bradycardia? It's hard to hold anesthesia too, or get interrupted.
Is the bradycardia the organization?
Lack of catecholamines, would y'all agree? Yep. Anything sympathetic is describing the actions of catecholamine. So they have hypotension and bradycardia. Somebody in the first class went ahead and did the interventions. He just did the whole thing. So guess what? What are you going to, so Ashley, how are you going to treat this neurogenic shock? Sure, but no, think about it logically and critically. You have hypotension. What would you like to do? You're at the bedside, you can do this. It's easy.
What's
And we use this a lot. So they're hypotensive. So what, so,
Fluids.
not yet. What if they can't sit up? So they're already in neurogenic shock, right? Is that gonna do anything really? I don't know. So what is your medical interventions for them? Oh, God.
oxygen?
They're hypotensive. Thank you. Gotta yell it. Say,
Everybody said
fluids.
fluids like 4 times.
Stop.
Like,
Fluids.
fluids and
I wanna hear
oxygen.
it. That's how loud it should be. Fluids. It should be.
here.
Is it simple?
I said that. She said that.
Said fluids like 4 times.
Vasopressors.
That's not pressors.
I said fluids and pressors.
I did not hear the fluids, I heard pressors.
Fluids, yes.
Fluids first for everything shock, distributive shock. We're gonna do that next week. So we've got fluids first. Do you want to hit them right away with pressors? Pressors are dangerous. If pressors give you cardiac dysrhythmias, yeah, you don't want to hit them right away. So sorry, I didn't hear the fluid. So give them fluids first. What are you gonna give them fluid? What kind of fluids? Isotonic, NS, done. So this is how it works. So you have a shocky looking patient. And what is your metron? Oh my God. They're hypertensive. This is when I make the decision to say, open up the mouth and ask for some norepinephrine. I need norepi, I need a liter halfway through that first liter. If I'm looking at the monitor and they are not responding to my fluid resuscitative efforts, I'll say, perhaps a levo drip, and the doc will say, yeah, of course, go. That's when I'll do it. Do I want to wait for that first liter? Not usually. If I'm not seeing the needle change on my blood pressure, heck no. I'm gonna start pressing them at that point. That's it. Those are your first interventions. Now, Terry, you said oxygen.
Yes.
He is not wrong in saying that, is he? Knowing the pathophysiology of shock is widespread hypoperfusion for different reasons. Vasodilation, is one of them. Do you realize we're doing shock next week? And we're doing burns next week.
Pass on that.
Are we gonna have so much fun? Yeah, we are. Very good, by the way. That was really good.
My enthusiasm.
Oh, what do you have, Miss Ashley? Your thing is going to be, Cushing's. Finally, we get to some Cushing. So what exactly is Cushing's disease? Yeah, would you agree with her? Cushing's cortisol. And what usually causes it? Whoa, good job. So what are your findings with let me see if that's, yeah. What are your Cushing's disease findings? Ooh, hyperglycemia, good. What? Moon phase? Yeah. How about up here?
Headaches.
Irritable, mood swings, yeah. Yep, bone fractures. Did you say the stria? Yeah. And what about the legs? Non-healing wounds? Because it's sugar or medium, it's very much like diabetes, right? And they're hypertensive too, because cortisol will cause you to retain fluid. Do they have male characteristics? Yep, they certainly do. So that's Cushing's. But do you guys know why? Because it's cortisol. The other thing that was mentioned in class, I just could have fallen out. I was swooning because of this answer. And it was another patient. It was another student who said, came out of his mouth, he said, hypercorticolism. And I just about fainted. So what is hypercorticolism?
Cortisol.
Can you have it for different reasons?
Yes, prednisone.
Prednisone, good job. So the folks who take chronic dosing of prednisone, they're gonna be hypercort all the time. It's sad, because it doesn't look good. You can have an RA person, they have a tiny, limbs, and they have a truncal obesity, they have the moon phase. They're immunosuppressed, they're blood sugar, we can't see that. But it's the same, it has the same look. The only thing that they don't develop, I noticed, is the buffalo hump. The Cushing's does have buffalo hump. What you want to do to treat that, so let's move on. I feel like saving another question for you. Let's just do it as a class. So how are you going to take care of it?
Diet management?
Oh, yeah, definitely your conservative measures like antihypertensives, diuretics, stuff like that. Ultimately, it's caused by pituitary tumor. Are we gonna, they need to take care of that, don't they? So how they gonna do that?
Chemo.
They're gonna get rid of that. They're gonna do some sort of ectomy, right? Hypophysectomy. You guys are speaking the language. This is exciting, very good. So it's up here, right? So no toothbrushing and watch for CSF leak. Very, very good. So you guys are thinking right. We were talking about like chronic Cushing's versus more acute things. The things that nurses really take care of are gonna be the insulin, taking care of the sugar, and making sure that they get a lot of education on immunosuppression. And watch for signs and symptoms of infection. If they have any wounds, we're gonna be treating that. Oh, finally we get to a dumping syndrome. What's dumping syndrome? Oh, absolutely. Oh, it opened up for me again. Yes. Let me go backwards. Nope. Yeah, it's fast dumping from the stomach, whatever's left of the stomach after.
So it could be kind of dangerous too. You do it differently.
The Whipple procedure, and what is the Whipple procedure? Yeah, it's related to pancreatic cancer. Do they take part of the cancer, part of the pancreas out, part of the stomach, part of the small intestine? They have to attach all that stuff. Is that scary in itself? Because could you have a leak, a gut leak, from those anastomose sites? I remember that from 1994, when my teacher was teaching that. I said, well, that makes sense. Because could they get pancreatitis, peritonitis from that? Yes, really bad, and you could die.
They're hypotensive.
Okay, so what's the other surgery that you could get the dumping syndrome from? Gastric bypass. So it comes down to one very, very important concept, is digestive time, right? Time of digestion, rate of digestion. You see where I'm going? Because does the body have to adjust or have time. If you have regular gut size, regular small intestine size, it's doing its thing. The pancreas, in that case, doesn't have time to gradually release insulin. It actually, so normal, so you're sitting here, you just ate a couple of hours probably ago, but you have normal digestion time. So your pancreas are going, oh yeah, I can handle this, because it's slower digestion time. Now, what does the pancreas do when it dumps from here to here? It's like, it'll react. Will it release too much insulin? Causing hypoglycemia. Is that dangerous? Yeah, that's dangerous. Now, what's the other thing that this dumping syndrome can cause? Hypotension, very good, secondary to what? Hypertonic bolus of fluid. Oh, you guys, this is when I start to get really tired, so bear with me. Plus I'm old, oh, poor thing. No, just kidding. So it dumps there, hypertonic, doesn't have that good digestive time. So what is the fluid going to do with that hypertonicity?
Sucked into the gut.
Exactly. And where does that fluid get stolen from? The vascular intervascular. Hey, that's very good. So you've got two major, potentially life-threatening things: hypotension and hypoglycemia. Would y'all agree? So guess what? Is that going to be what we're going to test you on? Yes. There are some other things involved with dumping syndrome, but I'd love to cut to the chase. Like, what is going to kill that patient? And that's it. All right. In medical surgical, is there so much to learn? Yeah, and is it possible for me to teach you every single, no, I can't do it. And you wouldn't retain it anyway. Not that you're not smart, you're very intelligent. It's just I have to give you the need to know important stuff. Okay, guess what I'm gonna take off the test? Fatty liver. Fatty liver will not be on your test. Could it be on the CMS? Yeah. So look up your causes, remember diabetes, alcohol, metabolic syndrome. Fatty liver is gone. What am I replacing it with? Pancreatitis interventions. So let's get into our pancreatitis. Oh, we're looking good here. So what exactly is pancreatitis? They could get infected because of the pancreatitis. So what is pancreatitis? Easy, right? Inflammation of the, yeah, because you got the itis and then the pancreas, right? But what causes pancreatitis? Alcohol. Yeah, alcohol is one of them. How about drugs? Certain medication, you know? There's other things that cause it, but those are the two major ones. All right, so let's talk about, before we go into treatment, how does your pancreatitis patient look clinically?
So there would be jaundice.
They could have some jaundice, would y'all agree?
Yeah.
But what's the number one symptom? Let's do symptoms first. Pain. And why do they have pain?
Pulmonary.
Because their pancreas is being attacked.
Yeah,
Yeah, that's it.
those digestive enzymes are trapped in there, causing auto-digestion of the pancreas. You know that that's bad. Those enzymes, lipase, amylase, tryptase, there's other ones that are in there eating your pancreas. Imagine how painful that would be. So number one, pain. Do they have nausea and vomiting?
Yeah.
They do. Do they have something around their umbilicus? Colon sign. What's the flank?
Great Turners.
Great Turners. Good. What about your lab findings? Increased?
White blood cells.
Elevated
Oh,
blood.
you know what? You're not wrong. You know what he said? WBCs. Yeah, slight. It's not like raging until they get infected. Yeah.
Fever.
Bilirubin.
Maybe a low rank temp. Immune system is working. What are your really definitive things? Gold standard for pancreatitis? Like, what's the first thing you're gonna look
Amylase
at?
and lipase.
Amylase and lipase. If you work in a hospital, it looks like a duck, squawks like a duck, i.e. pancreatitis, left-sided pain, history of alcoholism. I'm gonna go to my labs, my computer and lab. I'm gonna say, oh, that is pancreatitis. I pretty much almost have a definite differential diagnosis right there. There's one other lab I want you to add, it's hypocalcemia. Hypocalcemia, absolutely. And somebody said jaundice. Did you say jaundice? You were correct. Now, why would they be jaundice?
Increased bilirubin.
A buildup of bilirubin.
Yeah.
Why the buildup of bilirubin?
Liver issues.
Close.
Since the bilirubin is formed in the liver, that's why that.
And
gets
what's
built up right
common amongst the gallbladder, the liver, and the pancreas?
there. And it builds pressure.
The common bile duct. So if you have issues with pancreas, liver, or gallbladder, you have the common bile duct. So if you could have some jaundice with pancreatitis or cholecystitis. That makes sense, doesn't it? Because of the backup, that inflammation is causing backup ability in the liver. It's amazing, isn't it? Common bile duct. All right, so here we go. Do we have acute upper left quadrant pain? We do, right? After eating especially, we have a colon sign, we have a Gray Turner sign, we have jaundice, yes. Do we have some hyperglycemia? Yeah, because the pancreas is holding on to what? Pancreas and the islets of the Langerhans is making us, is it trapped? Can't squirt it out. Do we do blood sugars like every 6 hours, right? We have to check that. Good. There's one more that's very important. Does it happen on every patient? But it can be deadly. Systemic inflammatory response syndrome.
Oh, yeah.
Just by virtue of it being pancreatitis. The other one that can cause it, the other itis in here is peritonitis. Those two can be killer if it goes that far, right? This leads me to, why do they have lung issues in pancreatitis? Not all of them, but some of them potentially could. Is there a buildup of fluid in there?
Pulmonary edema.
And why would they be getting the buildup of fluid?
Pulmonary edema. Oh.
Pulmonary edema, secondary to what? Ooh, almost. Not wrong. Your pancreas, is it susceptible for infection? Yes. And then, of course, with infection, you get systemic inflammatory. But what if you just have plain out systemic inflammatory, which could happen, without infection? Is it related to systemic inflammatory? But how? How does that fluid build up in the lungs? Who said it? She said it. Did you say capillary leak? Gold star. I should start passing out gold stars. In fact, I think I'm gonna do that and put it like right there in your forehead. So when you're walking around campus, you're gonna have a gold star. And everybody's gonna ask you, what is that? So, well, I was smart today.
Wasn't smart yesterday, but I was smart today.
Huh?
Don't give it to Erin, she'll have a shiny forehead.
Oh, is that right? So do you see how that works? What do you have with systemic capillary leak and widespread vasodilation? I'll bet most nurses don't know that. You guys are gonna be so smart. When your patient with pancreatitis starts going, I'm having difficulty breathing, that is an assessment give that they could be going into systemic inflammation, which could kill them. hemodynamically ultimately. Because at that point, you could start seeing your blood pressure go down. Oh, you guys are gonna be so good out there. Sue, did you guys get all that information with the findings?
They're gonna be hypotensive.
Oh, yeah, they could if they get SIRS. And they're susceptible for infection that can cause SIRS. So Terry, you're not wrong in that. And can pancreatitis in the long run cause pancreatic cancer? If you get repeat bouts? Yep, it's a bad thing when you affect cells. So let's talk about, who's next? Is it Erin? Is it, she's always answering. So let's go to Julie. So what are your treatments for pancreatitis, which is going to be a question, by the way, that I'm going to send you, okay, in the announcements. I just have to create it, send you information.
I have oxygen.
If needed, right?
Antiemetic,
Ooh,
protonic,
yes,
nasogastric tube.
yes.
Did I say IV fluids?
I don't think so. And you're right,
And then TPN because they need.
if necessary.
Yeah,
So the TPN, the total parenteral, is in a very bad extended case.
okay.
So potential TPN. And did we do pain meds?
Yeah.
Yeah, okay, good. Did you guys get over that? Let's do it again. So pain meds first, right? Oxygen, PRN, because they may not initially have some respiratory issues. She said antibiotics, and could that be prophylactic when the white count really starts to go up? Yep. And then she said a PPI. And why a PPI? Do you just have hydrochloric acid in the stomach at this level because you have NG2? And that's the other thing she said, NG2, it burns, and you want to decrease that acidity in that stomach, because there's no food to break down from, yeah, that makes sense. It's sort of like when you have thrown up everything, I know this is a gross analogy, when you've thrown up everything, are you getting burny in here? You remember that feeling, it's the same concept. Might we give them insulin if necessary? Yeah, if their blood sugars are high, IV fluids, antibiotics. I think that's it, and certainly the IV fluids, they forgot about that this morning. Because, are they NPO? Yeah, of course. And decompressed with the NG2. Now, when they start eating, which is not gonna be a test question for me, but CMS probably, what do you have to give when they start eating? Enzymes. Who said it? Yep, correct. Lipase, pancreolase, yep. Very good. You guys are really thinking today. So definitely know the findings and the treatments. Almost done here. And we are making great time. You have 4 NGN, and can I confirm with you that I sent you the type and the topic, is that right? Good.
What was it again?
I think you told us.
Oh, I did tell you in class, didn't I? Did y'all get the notes? Okay, good.
I might have missed you saying that.
Let's do, here's a DKA, but, and who do we have, Julie? Or John?
She's already answered.
Oh, you did good, by the way. Yeah, this is when I start to get really tired.
These one?
DKA. Dawn H.
Oh, got that. Okay.
Diabetes type 1. They don't make insulin, right? So their pathways don't make insulin. What else do you have? Oh, she said it. Yeah, so, yeah, blood urine, so ketonuria, right? Good. And then what else did you say? I'm sorry. Yeah.
Thanks.
And what is your blood sugar with DKA? Greater than 300. So let's do a question. Let's do it. How about we do a select all the line? True or false? Sugar, greater than 300.
True.
Kussmaul's respiration. Neurologic findings.
Did it?
What am I comparing this to? Remember the side-by-side
Oh,
comparison?
HHS.
DKK, that's right, DKA, HHS. That's how it's gonna look on your test, and most tests. That's what they do with a lot of endocrine stuff, right? So let's do it. So let's start from the top. Greater than 300 blood sugar. Okay, good. Kussmaul's respiration. Good. Ketonemia, ketonuria. Neurologic changes. Hypovolemic shock. Usually probably not, right? Sugar greater than 600. You see where that goes. So what you really need to know are your findings to be able to treat that adequately. And you're not wrong, you're right about the type 1 diabetes.
You said ketonuria and what?
Ketonemia. That makes sense, right? Ketonemia is the blood, right? Yes. Urea is the urine. It's your new sophisticated language. Are they gonna be a little bit dry? Are they also polyurine? So let's go back to those findings. You know we just don't drop it at that. Why do they have Kussmaul's respirations? Blowing up CO2. Blowing up CO2. Because we know that CO2 is acidic, right? It is a respiratory compensatory form of taking care of a metabolic acidosis situation. So it's the fastest way to do that. Very good. Why do they have fruity breath?
Because of the ketonemia.
Ketones. And why is there ketones in the urine and the blood? It's a byproduct of the breakdown of
Sucrose.
fatty acids, right? No, it's good. And can are ketones potentially toxic to the brain? Yes, good job. Okay, what's the other one? I'm just doing this all by memory, like what's on the test here. I think that's pretty much it. Those are defined. Wait, what is it? She's so good. She's so good. DKA. Abdomen. Thank you so much. I would have gotten home and said, oh, I forgot. I have to send an announcement. Thank you so much. Abdominal pain and guarding in DKA. It's most likely because of the lack of, think about this. Do diabetics, especially type 1s, do they have neuropathies? Do they have gastroparesis? Yeah, this is kind of like a form of gastroparesis. They also have nausea and vomiting. So that's another part that comes along with abdominal pain. They also have NNV. Nausea and vomiting, right? And I don't know, did I mention that with sickle cell disease? Abdominal pain, or did I not? Okay, good. So remember those two with DKA and SCD, sickle cell. I'm gonna put those on your test. I'm adding those to your test. You know why? I do research all the time. I look at ATI, I look at everything. And I'm noticing that the abdominal pain is really almost on every test. The seniors came to me last Thursday. They were asking me about a question. Guess what? It was a DKA answer, right? And guess what were the two defining characteristics? Kussmaul's. But they described Kussmaul's. So you're gonna get the same question next semester in one of your midterm tests. So what does Kussmaul's actually look like? Deep and fast. Guess what? One of the other answers were shallow. So the ones, and I go, who answered D? I know you probably got it right. Because it accompanied some other things and the abdominal pain and nausea and vomiting. Yeah, thank you. That's very good. So can you do that on your test? Will you be able to, on your select all that apply, especially with the endocrine ones, differentiate between? That's what it's gonna look like. All right. Have we done liver? We have not done liver. Where's my liver question? Before we get to, no, let's do liver because I don't want to forget about it. Oh, it's a break time, or last break. Ooh, we're gonna have to get this last guy. You want to talk about? Wait, wait.